So this is the outline of what I'm going to talk about, and I'm going to cover items 1 through 7, which is long enough. I do give an additional talk on race and class disparities and some evidence for why something like single payer is, if you will, a necessary but not sufficient part of the solution, as well as a separate talk on prescription drug prices in the United States. So if anybody ever wants to invite me for either this talk or those other two, please do so. So let's talk really big scale, big picture, not just healthcare, and especially because there's sort of a generational divide between myself and the folks that are in residency programs currently. Let's talk about the world I grew up in and the transition that's occurred over the last 40 years and the world you are in currently, or we're all in currently. So I would suggest there's things that are somewhat better since the 60s and 70s and some things that are worse. So at the legal level, we have improved civil rights for African Americans, women, LGBTQI, better for legal immigration. If you look back to the Immigration and Nationality Act of 1965, and no doubt there are some other things that are better since then. Certainly the quality of a cell phone is better than it was in 1960, for whatever that's worth. Worse since, say, the 70s. Well, we've had a series of deliberate political choice policies that have worsened income inequality, wealth inequality, with basically the large majority of folks, relatively speaking, falling behind, such that even the upper middle class is feeling a certain kind of stress that they did not in the past. There was actually worse intergenerational mobility in terms of a multi-generational class divide. Many ways things have become worse in recent years for undocumented immigrants and refugees. And something you guys know far better than I, the cost of higher education and student debt. The United States is a laggard, as we will see in healthcare, compared to the other rich capitalist democracies around the world. And we are overall a laggard when it comes to income inequality. This is the so-called Gini coefficient, which measures complete equality. If every single person in the country had exactly the same income, then the Gini would be 0. And if one person had all the money and nobody else had any money, then it would be 1. And you can see here, the United States is on the far right, exceeded amongst the OECD countries only by Turkey, Mexico, Chile, and South Africa. And every other Western or capitalist democracy around the world, Western is the wrong term here, has less income and I would say wealth inequality than we do. And this is a new phenomenon. We used to be better. We've gotten much worse as a matter of deliberate political policy choices. This shows the top 1% wealth share, which prior to the Great Depression and FDR and the rise in income tax and inheritance taxes and minimum wage and labor organizing unions was high. It dipped as we implemented those changes starting in the 1930s, and it continued all the way, not just through the Great Depression, not just through World War II, but through the 50s, through the 60s, through the 70s, and into the beginning of the 80s, after which a series of deliberate political choices were made that have resulted in an increasing amount of money going to the wealthiest and a hollowing out for the much greater middle class. One of those policies is simply a matter of income growth. So what we see here in the blue is what income growth looked like between 1946 and 1980 in aggregate across different income percentiles. And what you see is everybody, it was a relatively flat curve, pretty much every income group had a annual increase in income of 2%, except the very, very wealthy above the 97th or so percentile, which only had a 1% growth. Compare that to the period from 1980 through 2018, where you see that only the upper 1% and fractions of 1% had phenomenal increase in their income. That's the red arrow shooting, the red bar shooting off to the right. And the 98, 99% of us, to coin a phrase, had much lower or even negative income growth in that period of time. Another reason is a change in tax policies. So the other was talking about gross income. This is a matter of tax policies. And again, what we see here is that real tax rates, not just nominal tax rates, but amounts actually paid, were much higher in 1950, 1960, even 1970, even into 1980, although you can see the drop off for the highest income groups. And working class, middle class, and upper middle class all were paying, slightly much lower amounts, and perhaps appropriately for which group they were in. And then what we see starting around between 1980 and 1990, it's already been on the way down from 1950 to 1980, but then it continues to decline such that by the time we hit 2018, the highest income groups are actually paying less in total real taxes than the other groups as a percentage. So again, what we see here in this case is worker wages have not kept up with what the overall economic productivity. What we see here is from 1947, after World War II, into the 70s, is that as productivity, think of GDP, think of sort of gross overall economic measures, as productivity went up, workers' wages went up commensurate with that. Workers' wages, which you could say are what's contributed to productivity, went up along with overall productivity, and then all of a sudden there's a change, and that kicks in the early 70s, and if wages had kept up with productivity, then the average worker would be making $1,258 a week instead of $697 a week. There's a huge gap there. And that gap is basically what's been extracted by the elite class. There's a gap between what the median worker and what the CEO make. This is polling of what Americans think it is and what they think it ought to be. So Americans think it's 36-1, and we think it ought to be 7-1. In reality, even in 1970, it was 45-1, and in 2014, it was 844-1. So it's just absolutely, folks have no idea how bad the inequality is in the United States, and that this gap, if you will, in perception and reality is a huge problem. Again, this is a political choice in the United States. It doesn't have to be this way. If you look at the other rich capitalist democracies around the world, the CEO to average worker wage gap is much, much less. So over 800 in the United States by this international comparison measure, and the highest other country listed here, 148, Switzerland on down. We can look at the official minimum wage. Again, the official minimum wage has not changed in many, many years at the federal level. If minimum wage had kept up with productivity, it would be over $18. If it had grown with average wages, it would be over $11, and in reality, the federal minimum wage is still $7.25. And there's something called the tipped sub-minimum wage. That's what, say, restaurant workers make, domestic workers. This was put in at the time of the original minimum wage laws overtly at the time. In Congress, overtly explained on racist and sexist grounds that women and as say waitresses and African Americans as domestic workers and Hispanic Americans as migrant farm workers didn't need to be paid the same amount. It was literally said so, and that is the historic basis for the tip sub-minimum wage, and it continues to this day and ought to be eliminated. Again, middle class wages, not just poorer folks, have not kept up over time, and this is what we talk about with the hollowing out and the insecurity of the middle class. There is a direct relationship, I would argue. Causality is not, always follows. Association and causality don't always follow. But this graph is somewhat suggestive, shall we say, that the share of the income going to the top 10% is inversely proportional to the percentage of folks who are union members. And as one went up, we had greater equality. And as the unions have gone down, we've had a greater extraction of money going to just the wealthiest folks. This increase in income inequality is true and bad for white Americans, but there is also, as there always is, a huge disparity by race and ethnicity. Median household wealth, because wealth is accumulated over generations. Median household wealth for white college graduates is, over 3 times that for white high school graduates. But even white high school graduates have a greater median household wealth than either Latino college graduates or Black college graduates in the United States. So again, this is pointing out both the racist disparities as well as class disparities, as well as the issue of multi-generational household median wealth by group overall. Again, whites far higher because of the cumulative history of racist economic policies in the United States. Household median wealth far higher for whites, shown on the left, than it is for Blacks, Hispanics, and others. So let's talk about healthcare, if that hasn't depressed you enough. Let's talk about all of those other rich capitalist democracies. How do they do it? Well, the answer is better. This shows you, for example, just how much we spend. And what you see here on the left is that the rich capitalist democracies were all sort of clustered, if you will, between 5 and 8%. And then over time, the other countries all gradually increased with increasing technology and costs of healthcare. But the United States' costs accelerated away from the others. So GDP, percent GDP of being spent on healthcare is greater and increasingly greater in the United States. We have a worse life expectancy, so we're not getting any bang for our buck there. Again, what we see here is back in 1960, the United States was middle of the pack on the left-hand side for life expectancy, and over time, as life expectancy has gone acceleratingly up for these other countries, the United States has diverged and is now substantially lower than any of the others, and that trend has continued through COVID. And if we model the two against each other, literally bang for our buck, to quote Sesame Street, one of these countries is not like the other. Again, the divergence is getting worse. And the fact that it's actually getting worse suggests that at least one of the excuses that's often given for this simply doesn't hold water. So one of the excuses is, well, the United States has its own unique history on racist disparities, and we have more immigrants, and we have more diversity, and we have all of these other things that are different in the United States, and that excuses or explains why the United States has a lower life expectancy, except that it doesn't explain the increasing divergence compared to the other countries. That hasn't gotten greater or lesser by comparison. Something else is going on in the United States. Another example of things are bad and getting worse is this is looking at avoidable deaths. So it's a subset of ICD codes that are considered to be avoidable mortality compared across different countries. And what we see here in 2009 in the lighter, I guess that's peach on top, is that the United States is worse than any of the other countries, about 280 deaths per 100,000 population. So comparing the peach circle across all of the countries, the United States is the worst. And then 10 years later, all of the countries have improved between, roughly somewhere around 15-20% improvement, looking at the lower, darker orange color. In 2019, the United States has also improved, but that improvement is far less than any of the other countries, such that 10 years later, we are still worse than all the other countries were 10 years ago, and our improvement is far less. So again, avoidable mortality, our healthcare system is not doing as good a job, and it is lagging compared to the other rich capitalist democracies around the world. Other countries are not rationing. You often hear this as an argument against single payer. They're not rationing. We are, of course, rationing by ability to pay and ability to access care. If you look at hospital inpatients days per capita, the U.S. currently provides less inpatient care than these other countries. They provide more. They're not rationing on inpatient care. If you look at the left side of this slide, what you will see is average outpatient visits per capita. And again, the United States is towards the bottom. We're not the very bottom here, but we are certainly well below the OECD average. So overall, the United States is the one that is rationing on outpatient visits per capita. And in fact, one of the reasons for that is we don't have enough doctors. So if you look at practicing physicians per population, the United States is towards the bottom on that. And it's somewhat important to note because we often make these comparisons for better or for worse with countries like Canada and the UK. And while I would say the United States does the worst across healthcare systems, actually there's a good argument that for all of our loving of Canada by comparison, in many ways the Anglophone world and Canada and the UK, for very different reasons, are second worst and third worst, perhaps. This is, again, looking at the issue of rationing care based on a multinational study on self-reporting percentage of folks who reported any cost-related skipping doctor's visits, skipping tests, skipping prescription meds, self-reporting, but same methodology across all the different countries. And what you see here on the far right is amongst the lower 20%. So this was, I believe, in quintiles by 20 percentiles. The 50% of folks in the lowest 20% reported skipping healthcare, but even in the highest 20%, 27% reported skipping healthcare in the United States. By comparison, across the other rich capitalist democracies, what we see is that their lowest income folks skipped care less than our highest income folks. So again, we put up barriers to care. We ration care. We just do it by out-of-pocket costs. And again, overall healthcare system. This is a system performance scale done by the Commonwealth Fund and OECD. And again, just looking at a 10-country average. You see a cluster in the center top of the rest of the world, and down at the bottom right with higher spending and lower system performance. Again, one of these countries is not like the other. It's the United States. We have excess deaths due to uninsured and underinsured that are far greater than other countries. On the left-hand side here, you see studies within the U.S. that have looked at the number of excess deaths per year due to being uninsured or underinsured. Folks in the single payer movement often cite 28% higher mortality and 18,000 excess deaths per year. I actually want to point out the lower number. So the lower number I'm sorry, 68,000 excess deaths per year and 28% higher mortality. But I want to point out the lower number, that's 6% higher mortality and 18,000 excess deaths per year. That lower number is from a study that was self-described as supposed to be a debunking study by some conservative researchers. And so the conservative researchers trying to debunk the high number said, well, it's only 6% higher mortality due to uninsurance and underinsurance. It's only 18,000 deaths per year. And that's the debunking study. On the right-hand side, what we see is the cumulative excess deaths over time in the United States compared to the other countries. If we had the kind of access to care that they do, we would have 500,000 less missing Americans. And I just want to point out, especially this has now been carried out all the way back from 1933 forward to 2021 in an absolutely brilliant study that's now been published in PNAS. So let's talk about the American healthcare system by comparison to what we just saw. We are uninsured, underinsured, it's too expensive and just too complicated. So let's talk about the completely uninsured first, because that's often what gets a lot of attention. I would argue it's actually not the driving problem. It's a sin, but it's not the only problem. And there is a huge misconception as to who are the remaining uninsured. Now, it's different in New York State, but nationwide in the United States overall, it is not primarily folks who are ineligible for assistance due to their immigration status. In other words, it is not principally undocumented folks. Overall, that's about 16% nationwide. In fact, the remaining uninsured are overwhelmingly folks who are eligible, but are not enrolled for one reason or another. Either it's still too expensive for them and they've made the choice to not be enrolled in anything, or they're caught up in the churn of being on and off different eligibilities and different insurance, or they just haven't been able to navigate the complicated enrollment process and so on and so forth. And I should point out that 9% would be eligible for Medicaid if their states had expanded per the ACA Medicaid expansion. But again, even that, which we on the progressives often point to as an issue, yes, it's an issue, but overall in the United States, it's only 9%. Overwhelmingly, it's the issues of too expensive and too complicated. But let's talk now about underinsurance and too darn expensive. This is what's showing the difference in worker earnings and overall economic inflation rates shown in the blue. And by comparison, what we see is that the cost to pay the premium to buy insurance is rising at about twice the rate of workers' earnings and overall inflation. And then above and beyond that, even after you purchase that insurance at twice the inflation rate, your out-of-pocket deductible, the amount of money you have to pay before the insurance even begins to kick in, has tripled above and beyond that rate. So you're paying more and more for the premium, and then what you're buying with that insurance is requiring you to pay more and more out of pocket anyways. Another problem is narrow networks. Now, we often talk about narrow networks in the sense of I have a managed care plan, and Montefiore takes my health insurance plan, but Mount Sinai doesn't take my health insurance plan, for example. But in addition, the narrowest network of all is one of the largest health insurance programs in the United States. It's Medicaid, because so many physicians just don't take Medicaid. Now, as a general pediatrician, I am actually proud to say that over 2/3 of general pediatricians in the United States do take Medicaid. But the moment you get to pediatric subspecialists, the overwhelming majority do not take Medicaid. And so this shows amongst pediatric specialists, in the dark blue, the percentage that take private insurance, and in the light blue, the percentage that take public insurance. So if only 1 out of 4 doctors takes your insurance, you have an access issue. Another issue are copays and deductibles. The amount of money you have to pay out of pocket as a patient to actually, let's say, get your medicine or get access to care out of pocket, even though you are insured. So there's been unfortunately a large number of studies with natural experiments, if you will, where entire cohorts of people have been switched over from fee for service to various types of so-called managed care, or from a regular health insurance plan to a high deductible plan, where they have to pay more out of pocket than before, before the insurance even kicks in. So this was showing the folks who had a group of folks who had non-specific chest pain, who transitioned to a high deductible health plan, and that successfully reduced costs to the insurance plan, in that folks who were experiencing non-specific chest pain had 4.3 less emergency visits. They had 11% lower hospitalization rates. They had almost 3% less invasive testing within 3 days of having had that non-specific chest pain. Oh, and by the way, they had a 16% higher rate of acute myocardial infarctions 30 days out. So a case of skin in the game kills. Another case shown here is with a increasing charge in the copay for drugs. This was an average increase of $10.40 per prescription filled, which was a 34% increase from what it had been before in this group. Again, what happened is these are folks who are already on various typical common medications for various chronic diseases. And what we saw is, yes, indeed, the system saved money with lower numbers of prescriptions filled overall, and for statins, ACE inhibitors, inhalers, and oral diabetes agents. And by the way, they had a 33% increase in mortality. This has been replicated across numerous other studies, that when you flip a population to higher out-of-pocket costs, they will limit their needed care, and they will have bad outcomes. This entire emphasis on restricting overuse as a way of controlling costs is a fallacy, period. Health spending, in fact, is driven by very, very sick people spending a lot of money. It is not driven by overuse on the margins of people who maybe don't really need it. This is actual data from the Medical Expenditure Panel Survey, analyzed by the Kaiser Family Fund Foundation. And what it shows, and this has been consistent over many years, it hasn't changed, this is the 80-20 rule, that basically the top 1% of people with the highest amount of healthcare spending, the top 1% account for 20% of all spending, and in fact the top 20% account for 80% of all spending. So it's a small people with serious, real, non-voluntary care that accounts for most spending. You see this all the time: ER visits for a motor vehicle accident or heart attack, cancer care, surgery for significant real things, ICU care. That's where the money is actually being spent. And adding a moral hazard, as it's called, the copays, the deductibles, out-of-pocket costs, isn't going to have any effect on reducing system-wide costs. It does prevent and delay necessary care, resulting in death and other bad outcomes. The United States is the only country that has this kind of medical bankruptcy, again, amongst the rich capitalist democracies around the world. And just want to point out that not only is medical bankruptcy the leading cause of personal bankruptcy, with over 2/3 of those filing for personal bankruptcy attributing healthcare costs as the single major factor, but over 2/3 of them had health insurance when they became sick, and they still went into personal bankruptcy, even though they ostensibly had health insurance. During the mortgage crisis, 60% of people lost their homes due to foreclosure, identified medical debt as the major cause. They weren't able to keep up with their mortgages. Medical bills are far and away the single most common cause for collection calls, 60% compared to all other causes. 18% of credit reports include medical bills in the collection, and it's the most common cause for personal GoFundMes. So, in summary, having private health insurance is kind of like having a hospital gown. Even if you have it, the chances are your ass isn't covered. Again, what it doesn't cover when you get sick, those copays, deductibles, out of network, unreimbursed out of pocket, the trade off of lower premiums in return for having lower premium for higher or lower premium for more or less out of pocket when you do get sick. Nominally, you have insurance, but if you get sick, you still go bankrupt. And of course, limited networks, nominally, you have insurance, but you still can't actually access care that's needed. So we have another nice natural experiment that occurred because right around the same time that Canada was moving to all the provinces having their version of universal coverage, the HMO Act, which put a floor standardization across all the provinces for having coverage. I'm sorry, the HMO Act in the United States, which was signed into law by Richard Nixon, which basically opened up the floodgates to third-party for-profit care. So it's with the HMO Act that we see not-for-profit HMOs becoming for-profit. It's when we see the Blue Cross Blue Shield insurance companies going from sort of a public nonprofit utility model to being bought up and converted to for-profits. It's when we see the hospital chains, the for-profit hospital chains expand. So at the time that Medicare was what Canada calls Medicare was fully implemented, and in the United States, we opened up the floodgates to private. So this is your classic public in teal and private in red. And so at that time, the United States and Canada had roughly the same healthcare costs per GDP. And when they went public and we went private for profit, what we see here is a increasing divergence where the increase in cost per GDP for Canada went up a little bit and the United States went up in an acceleratingly divergent fashion. So this is a case where going private actually has been less efficient and is costing money. And during that same period of time, we have a increasing life expectancy gap where it went from a gap of 1 year to a gap now of over 3 years. So the real problem indeed, from one perspective, is that healthcare is too expensive. The solution over the last 40 years, what I would call their solution, is to make it more difficult to get. And somehow that's going to control costs. So we've had 40 years of free market, for-profit, so-called reform. I hate that word. And what has it resulted in? Well, it's adding more middlemen to extract profits. That's what pharmacy benefit managers are. That's what Medicare Disadvantage is. They raise the unit costs, so drugs and equipment and supplies and labs all cost more and more and more in the U.S. compared to the other capitalist democracies around the world. And there's an increasing diversion or extraction of dollars by the for-profit, including both public for-profit on Wall Street and private equity, extracting more dollars and a higher percentage of those dollars to themselves and away from care. And again, we've seen where this occurs in terms of limited networks, the out-of-pocket costs, restricting coverage, prior authorization, but also monopoly power driving up unit costs, and investor-owned for-profits where there's a demand to have a quarter-on-quarter increase in earnings and or profit. And again, this is causing harm to our patients, but it's also causing harm to us physicians and the hospitals and other places. It doesn't control costs. It does limit care. So as George Carlin said, I don't believe that there's any problem in this country, no matter how tough it is, that we Americans, when they roll up our sleeves, can't completely ignore. And that's what we've been doing for the last 40 years. Now, there is a solution, and Medicare as is suggests what that solution is. So this is looking at the age group specific mortality rates. So age group specific mortality rates. And among 17 peer countries, again, rich capitalist democracies around the world, the United States is pretty much dead last overall in these age group specific mortality rates until the age of 65. Lo and behold, what happens at the age of 65? Well, all of a sudden, the U.S. relative ranking in the age group specific mortality rates improves up to the point where in the elders, we are actually number one. What changes at age 65? More or less universal coverage with Medicare. So, if that's good enough for the over 65s, how about everybody from age 0 onwards? Or as my dad told me in the 1970s, we ought to have Medicare starting at age 0. So what is single payer? And by the way, how does it do this magical thing of saving money while covering everybody and with more comprehensive coverage? We'll come back to this slide at the end, but in terms of testing any proposed model, I suggest you need to ask, is it USA? Is the healthcare USA? Is it universal, simple, and affordable? So why do doctors and hospitals not necessarily support a single payer? Well, there's certainly the fear of the unknown and fear of change. There's fear of the loss of personal income and institutional revenue, and there's some sort of faith in the private sector, and related to that faith in the private sector is some sort of generic USA is number one. So I would suggest let's not have fear and faith, but let's look at facts and evidence. Now, we need to go back to very first principles here. So, what is the point of having an insurance pool? Health insurance is just one type of pool. But if you go back to Lloyd's of London, being founded during the peak early mercantile period in England, sending ships out around the world to engage in what some would call trading and others would call resource extraction. When a ship went down, it was too expensive even for the rich elites in the UK to pay for it. And so they created the idea of an insurance pool on a larger scale than it ever occurred before. And the idea is, well, if everybody is paying in a little amount all the time, then there's a pool for events when it's needed. And that's what we mean by the term risk pooling. So we have a slogan about everybody in and nobody out, but actually it's an economic insurance pool term, technical term if you think of it, because the most natural and efficient risk pool for an insurance pool of money is everybody. So by comparison, what is the business of the for-profit corporate health insurance? Well, their business is for profit. That's their fiduciary legal responsibilities to make money. And healthcare is actually their loss leader to get you to pay them the premiums. They actually call it medical loss ratio. That's their term for healthcare. And the way they make money is not by creating some sort of efficiencies and oversight of care and things like that. The way they make money goes back to the point of an insurance pool. They cherry pick, they compete to select the less sick and those with more money. So they cherry pick for the healthy and wealthy, and they lemon drop back into the public pool anybody who either becomes poorer or becomes sicker. So that's what makes the insurance company's money what you might call advantageous selection. And what it does is it makes the public pools, Medicare, Medicaid, and subsidies like giving money to people to buy private insurance, whether that's Medicare Disadvantage or the subsidies on the ACA exchanges. It makes those pools more expensive due to adverse selection. One last point about healthcare economics is it simply does not follow simplistic supply and demand. We've known this in studies in the mid-60s by a guy named Ken Arrow. But basically, to have supply and demand, you have to have perfect knowledge. The consumer has to have perfect knowledge and an ability to make choices. And the supplier has to be able to adjust prices in response to that demand. None of that exists in healthcare. The general public, before sick, and patients when they're sick, don't have full information. They cannot negotiate and shop. Oh, I have a heart attack. I'm in the ambulance. Should I check out how much it's going to cost for my catheterization and cabbage at Sinai versus NYU on the way to the hospital? No, of course not. There's a complex three-way between the patients who get the care, the doctors who in effect control who gets care, and the payers. The doctors and the hospitals drive demand, the payers try to slow demand, and the patients are caught in between. So what is single payer? publicly funded, privately delivered. Universal coverage, it's a change in the financing, not the delivery. Progressive funding with a replacing the current flat tax in effect of premiums, copays, deductibles, and out-of-pocket costs, where a rich person, the CEO of a company, the CEO's support person, and the janitor all have eligibility to pay the same premium for the same employment-based plan at that company. That's at best a flat tax. Paid for progressively, over 92% save money. All providers take it, and everybody just has it. It's not the same as current Medicare as is, because it's a more comprehensive benefits package. All medical, mental, dental, hearing, vision, drugs, devices, and very importantly, because nothing else really covers it, long-term care. No point of service costs, those copays, deductibles, etc., out of pocket when you pick up your drugs, or out of pocket when you make an appointment to see a doctor. Access based on need, not means. And to use some conservative buzzwords, I would suggest that this increases freedom of choice for all patients. Patients are now free to choose amongst all doctors and hospitals, healthcare providers, and pharmacies. In fact, it's the best of capitalism in that the providers are now competing for the patients to get them on an even playing field, not on the basis of which are the better paying patients. And there's greater security. You just have it all the time, forever, regardless of any changes in your employment or life circumstances. We'll talk about the economic arguments for why this is better. I've already alluded to some of them. But it's also a moral argument in terms of, do we perceive of healthcare as a private for-profit commodity to be purchased, like our widget du jour, or is it a social communal need like the fire department? If your house catches on fire, the fire department just comes and puts it out. They don't anymore, at least not since the 19th century. They don't argue over which fire company is going to provide the care and duke it out on the streets before putting out the fire. They don't ask you for some money up front at the point that the fire is already occurring and ask you for some out-of-pocket costs before they'll put out the fire. You've already prepaid for it. So, first of all, it makes economic sense. There's 30 studies, including the Congressional Budget Office in 2020, 2022, saying, yes, indeed, we, conservative, mainstream economists, not activists, we agree. If we implemented single payer, it would actually cover everybody with broader coverage and save on average 5.7%. So it actually reduces costs, not just this stays the same or increases them, reduces total system-wide costs while improving coverage, increases net increase in workers' earnings if we do it, increase in longevity and labor productivity, a net increase in economy-wide productivity. And the RAND Corporation, a center-right group, if ever there was one, estimated there would be a net increase of 180,000 jobs in New York State with the New York Health Act. There's numerous studies on this, including various multi-study analyses and comparisons and collections. So where do these savings come from? First of all, we pay more in our administrative insurance system. So to administer that insurance pool from the insurance pool or an insurance company side, the cost per capita in the United States is roughly 5 times that of other countries. So this is the cost of having Aetna and Cigna and all the other private for-profit insurance companies, and the increased overhead costs of having that administration and that churn and that profit making, et cetera, compared to having a more public universal system. It's actually more efficient. So again, this whole idea that somehow the private sector is more efficient than the public sector, no, in this case, for sure, it is not. Because of their need to extract profit, the commercial health insurance costs per enrollee spending have gone up far faster than that for Medicare. Fee-for-service public Medicare, original A and B, costs have gone up at a much lower rate over extended period of time than the commercial health insurance. There's big savings, again, on the insurance side. Another way of looking at it here is that the administrative overhead for Medicare as is, the fee-for-service plans, A and B, is 2%, and corporate health insurance at best is running around, say, 15%. Now, that was the cost to administer the insurance scheme from the insurance scheme side. Let's flip it and look at how much does it cost the providers to deal with the insurance scheme. So when you, again, have this multi-payer system, different patients have different companies that you have to bill at different rates, and then haggle and fight over actually getting reimbursed. The outpatient physician billing related expenses in the United States are about 5 times that of Canada, and similarly for the other rich capitalist democracies around the world. Similarly, on the hospital side, for the hospital billing administration dealing with the insurance companies, it's costing them about 5 times what it does elsewhere. This is a classic example, Duke Medical Center. We're picking on Duke only because it's published in JAMA. So Duke Medical Center is 3 hospitals, 957 beds, and they have 1,600 billing clerks. They have more than 1.5 billing clerks per bed. Toronto University Health Network, academic university medical center with some satellite hospitals, 1,272 beds across 5 hospitals, 7 billing clerks. Literally. At the main academic medical center, they have 3 billing clerks. Essentially, they have 1 for Ontario, 1 for the other provinces, and 1 for the rest of the world. There has been a massive growth in healthcare managers, far greater than there has been in healthcare providers. So this is data from Federal Bureau of Labor Statistics, the National Center for Health Statistics. And what we see is between 1970 and 2021 is there has been a 4,000% increase, 40 times increase in the number of managers overseeing physicians. This is healthcare managers specifically, that's in the blue, and a small doubling of the number of physicians since 1970 to 2021. So this, again, doesn't have to be, it's a series of deliberate public policy choices, basically pushing privatization and for-profitization and financialization. Let's look at drug prices. Well, U.S. drug prices have increased consistently at twice the background inflation rate. For any given drug, we pay between 1.5 and 12 times the OECD price, the rich country's price for any given drug. Remember, these drug companies are all transnational companies. These are all essentially the same drugs from the same companies. It's just that the United States is subsidizing excess profits worldwide, compared to worldwide. And I have a whole talk, separate talk, that could be invited back for to give on drug pricing, why it is in detail, and what we can do about it. So year over year, what we see here is over 300% and over 700% for generics in the increase in costs, as you just each year are way above the inflation rate and it accumulates. Most of that pharma revenue is not going to research. Remember, basic science research in the United States is all publicly funded. That's what the NIH grants are. And even according to the drug companies, research and development is 13%. And let's just say under that research and development, you can imagine what gets tucked away in there that you and I might not actually call research. Mostly marketing administration, yes, manufacturing, and profits after taxes. I should note that the United States, again in 1980, back at the beginning of that whole neoliberal period, passed something called the Bayh-Dole Act, which basically was a change in who had the patent right. So previously, before the Bayh-Dole Act, the NIH, meaning the taxpayer, shared in any of the patent rights. And after 1980, that was actually made illegal, so that only the researchers and then who they contract with, in terms of the going public with a drug, is the one allowed to profit. And it also made it harder to even oversight any patents and pricing subsequently. Pharma has a higher return on revenues than the Fortune 500 average. I don't actually want to put the drug companies out of business. I love my statin. I love my ARB. I just want to fairly negotiate the prices so that we are paying the same price for the same drugs as Canada, the UK, France, Japan, Taiwan, New Zealand, Denmark, Germany, etc., etc., etc. The United States is essentially subsidizing excess profits compared to the normal profits that they are making everywhere else. And that's because the US is the only country that doesn't systematically negotiate all drug prices from a position of what might be called monopsony, which is the technical term for where the buyer has a monopoly. But wait, it gets worse. So pharmacy benefit managers are a classic example of bait and switch with adding in middlemen. Now, I would say that you inherently never save money or increase efficiency by adding an additional layer of a for-profit middleman. That's what pharmacy benefit managers are. That's what managed care is. That's what Medicare Disadvantage is, etc., etc., etc. But they originally were sold as, we'll put in a middleman to a pharmacy benefit manager, and they'll negotiate between the drug companies and the retail and the insurance company and the consumer for how much the prices being paid for the drugs are. They'll keep some of the money for their own profit, but they'll pass the rest of those savings on to the consumer. So that was the original idea. The problem is that the insurance plan, the pharmacy benefit manager, and the pharmacy are now all the same company. So CVS Pharmacy owns a pharmacy benefit manager, Caremark, and it owns an insurance company, Aetna. Same for United, same for Humana, same for Cigna. And of course, they're all going into the primary care business, so they're now also going to control the doctor, provider, caregiver who writes the prescriptions. And so basically each one of these becomes its own additional profit extracting center. And between accounting gains and payments and charges and shifting of overheads between divisions, they hide what the true net profit making is. And with monopoly power, they're able to raise prices. So if we put all of this together, we can see where the how single payer financing works. So in the red here, we see those reduced costs due to the insurance administration overhead, reduced costs for the physicians and hospitals to the administrative overhead, and the reduced prices for drugs. And what we talked about for drugs applies for other devices and supplies, the $2,000 bag of saline, the $20,000 hospital bed, etc. So there's total savings there. We have some additional costs because we're now covering everybody and eliminating cost sharing. No copays, no deductibles. We're actually improving provider fees overall, and especially for primary care. We're adding in long-term care coverage, so that means elder home care where possible, and residential care like nursing homes where necessary. And so we have an increase in total cost because we're doing more. And it turns out there's a net savings. And in the case of the center-right Rand Corporation for the New York Health Act, they predicted a net savings of 3.6%. So progressively paid for. We'll talk about this a little bit later, but basically, currently the premium and the copays and deductibles are all the same if you're rich or poor, except if you're poor, you probably have higher copays and deductibles because you got more illness. Single payer is on a progressive tax basis, eliminating the others. So the higher income folks pay a higher marginal percent. This is an example of what we mean by that. So single payer in this model, the top 95% of households would pay more. In 2013, that was folks with a household income of above $463,000. Those folks would pay a higher percentage. Lower income people would pay a lower percentage, which means, in effect, 95% of people at the end of the day would not only have guaranteed universal health care coverage, they'd have more money in their pocket each month. Basically, it's a way of getting their income up. One of the inherent things with single payer is that all the lower levels of government, lower than the single payer level, save money. So with national single payer, the states, cities, and counties pay less. With New York Health Act, state single payer, New York City and the counties and jurisdictions around the state would all save money. There's essentially three reasons. In New York, we have a specific thing where the county and city pay 50% of the Medicaid to the state. So 50% of Medicaid in New York State is paid for, of the state's share of Medicaid is paid for by the cities and counties. That's eliminated. And by the way, well, I'll come back to that in a moment. So there's government as an employer, right? So the city government pays for teachers. The city government pays for police, etc. Well, those employees have employee health benefits and retiree health care benefits. And the city and counties as an employer would be saving money with the New York Health Act or single payer. And finally, public hospital and charity care, which is now paid for either as a loss if the persons can't pay, or at a lower reimbursement rate if it's Medicaid or sliding fee scale. They're now reimbursed in full at the same rates as the rich people's hospitals. So basically, there would be massive savings in the healthcare costs to local government. And if you look, for example, at the property taxes in the county level, on average, 50% of the property tax is going to healthcare. So if I turned around and told you you could reduce your property tax by 50% and have guaranteed universal health care coverage, I think I could sell that for most localities in New York. So the big lie is it's too expensive, and the big truth is it's cost saving and cost shifting. Basically, yes, it's a misdirection. So whenever they say it costs too much, what they're saying is whatever level of government is the single payer is now paying a lot more. And that's true. National single payer, the federal budget goes up. New York State single payer, New York Health Act, the New York State government budget goes up. But the total system costs go down, and there is savings for all of the individuals, households, families. There are savings for all the lower levels of government, and there are savings for all employers that are currently contributing to the healthcare system. And on average, there's a savings of $9,000 per employee for employers if they are currently contributing to their employees' health insurance. And by the way, for a small business, that includes the owner. So it's the current system that's broken and too expensive. Let's talk about doctors and physician support. So why should doctors support this? Isn't single payer going to make me a pawn of the state and lower my income? No. First of all, the current system is making you a pawn of the insurance companies and your employer. So most physicians, in fact, are already corporate employees. 52% are hospital employees, 22% are employees of other corporations, private equity, venture capital, that sort of thing. A trend that was already present, accelerated with COVID. So the private practitioner hanging out their own shingle, being their own self-employed entity, is going the way of the dodo. U.S. physician personal job satisfaction is the lowest amongst the rich capitalist democracies around the world. Sorry, guys, but satisfaction levels are lower in the U.S. than elsewhere. U.S. Physician rating of our own healthcare system is the lowest compared to the other countries. We really don't think our country is doing the best. Let's take a look at how much time you are able to spend with patients. This is a study across multiple ambulatory care practices on the left, showing 26% of time spent with direct patient care. Similar, not exactly the same methodology, I will acknowledge in this example, truth throughout this storytelling. 57% time with patient care in Canada. So less time spent at the desk, either doing the EHR or other admin. Let's look at EHRs. So Epic, which I think you guys use at Monty, is probably the most widely used electronic health record or electronic medical record. It is also used, by the way, in other countries. So this is showing the distribution curve for the average number of keystrokes, the average number of characters per ambulatory care note in the United States. It's shown here in red. And we see a distribution curve of how many characters it takes to close an ambulatory care note in Epic. However, it's also used, this is showing 13 organizations in other countries around the world in the teal, and using Epic, modified for their healthcare system, but the same software product ostensibly, in the setting of other healthcare systems. And what we see here for those 13 organizations in other countries, and this is just one study, it's been replicated several times, and within each study, they're using the same methodology in the international comparison compared to the US. And what you see here is zero overlap. At best, in the United States, we are spending more time typing in our notes than the highest in other countries. Why? Because it's not a medical record. 3/4 of our charting is for billing and insurance. That could be gotten rid of. It's not even inherent in Epic or the EHR. It doesn't have to be this bad. Well, what about incomes? Well, this is showing American Canadian physician incomes. It is using standardized comparative data. And what we see here basically is folks in US and in Canada make roughly similar incomes. Weirdly, ophthalmology does a lot better in Canada. Primary care generally does better in Canada too. And everybody's making a good living. Nobody who's a physician is being impoverished. Everybody who's a physician is in the upper income groups, wherever they are. And yes, the specialists make more than the primary care practitioners in the other countries too. Again, US physicians are spending a lot of time and money managing the insurance companies. Amount of cost for a physician practice interacting with insurers, which means those folks who are actually independent practitioners still are spending more money out of their practice on overhead, and they are retaining less as income. In fact, the American physicians are on net moving to Canada, not the other way around now. And this has been going on for a while. Now, there are both push reasons and pull reasons for this. So I should acknowledge that not only is it, frankly, greater job satisfaction, less hassle to practice in Canada than the United States, but there is also an increasing shortage in many areas of Canada, both geographic and by specialty. There's a shortage in Canada due to specific Canadian neoliberal conservative policies. And in fact, not only are physicians moving, American physicians practicing in Canada, there's a net migration of Canadian physicians back to Canada. What about total payments to physicians if we go to Medicare for all? So there's 3 recent estimates by single payer opponents. So 3 single payer groups that are either skeptical or active opponents to single payer. The Mercatus Institute, which is a quote-unquote think tank funded by the far-right Koch Foundation folks, Rand Corporation, center-right if ever there was one, and the Urban Institute, which is affiliated with, if you will, the neoliberal wing of the Democratic Party, if I may use the word, the Clintons. All 3 of them agree that compared to the current system, under Medicare for all, the total amount of dollars that would actually go to physicians would be higher. Current system in green, Medicare for all in yellow. So even Mercatus, Rand, and Urban Institute agree more money for physicians under single payer. physicians, Merritt Hawkins survey. They're a HR company, that for hiring. You put your resume into them, they'll help you get jobs with groups that are hiring. So they do some market survey stuff for their business, which is in part healthcare workers. And what their survey showed between 2008 and 2017 is that physician support has gone from 42% to 56% for a single payer. It's not the greatest. Their survey methodology is not the greatest. The other one that's out there, which is a superb methodology, peer review publication by Ackerman and Carroll. This is, I believe, the Aaron Carroll, who does a pretty well-known medical blog. So this was published, I think, in Annals of Internal Medicine. 2 studies. One was 2002 data. The other was 2007 data, so 5 years. And what it shows is increasing support for national health insurance. So for one thing, going from 49% to 59% in 2007, and one could only presume the trend has continued upward since then. I would also point out that in the study's details, there's differences, of course, by region of the country, as you might expect, and also as you would expect by specialty. And again, I'm kind of proud to say general peds at the highest levels. Organized medicine is changing. The AMA had the vote in 2019 you may have heard of, where they have a written opposition to Medicare for all, and there was a vote to remove that and go neutral. It failed 53 to 47%. So 47% said, let's stop opposing Medicare for all. That's relatively speaking a victory compared to where it's been historically. And of course, a small minority of physicians actually belong to the AMA, less than 20%. Most physicians belong to their specialty society. The ACP, representing internists nationwide, in 2020 announced that there were only 2 ways to go forward, either Medicare for all or a strong, real public option. The Society for General Internal Medicine endorsed Medicare for all. APHA, American Public Health Association, endorsed Medicare for all. And here in New York State, both your academy and my academy, at the state level, state American, state pediatrics and state family practice have endorsed the New York Health Act. So again, preserved earning potential, increased professional autonomy, increased career satisfaction, and just ease of life. And let's get back to doing healthcare. Better for hospitals, I would argue. And I have about 10 minutes, I'm told, so I'm going to about 10, 20, 25. Fewer hospital beds, as I noted before, in other countries. So again, the U.S. is not rationing care. Other countries, on average, have more hospital beds per population than we do. They are staffed differently. So in the United States, we shown on the right here, we have relatively fewer healthcare workers, but a lot more administrators. So administrators shown in red, and you can see hospital administration is less, about a third less in other countries, and they have more doctors working at the hospitals. It's the current financing system that's failing hospitals. Now, there is a good argument over the trend line going back to the 70s through the present. If you compare lengths of stay, way down. If you compare more being done outpatient, legitimately because of technology and changes in care standards and abilities, there's a good argument that indeed we don't need as many beds as there used to be. But the reality is that where those beds are closing is disproportionately in rural areas and in urban poor areas. And it is not happening in rich and suburban areas. They've continued to grow in their number. So between 2015 and 2020, 160 hospitals closed. There's been a huge, you think it's bad in the Bronx, there's been a huge amount of closures in rural America, such that the average travel distance for a person living in rural America has gone from 3.5 miles to 24 miles. So that's a real concrete example of decreased access to care. Here in New York, what we've seen is a dramatic closure in the number of beds per population. And lo and behold, it's mostly in the poorer neighborhoods. Midtown East Side, Bedpan Alley has not had those closures, such that as we headed into COVID in 2020, Queens, the original epicenter, along with the Bronx, of the outbreak, had 1.5 beds per 1,000 persons, and Manhattan had 6.4 beds per 1,000 persons. One might call this medical apartheid, separate and unequal. And in fact, when it comes to allocating something called the Indigent Care Pool funds, which is a combination of federal and state funds that's supposed to go to safety net hospitals only. New York State's one of 3 states that sends some of the ICP money to all hospitals. And in fact, we are the 50th out of 50, not just 47th out of 50, in the maldistribution of the Indigent Care Pool funds. Structural racism, literally, this is the value, capital value of new purchases and total assets of U.S. Acute care hospitals. Basically, hospitals that serve a mainly white population have more assets and are able to spend more money on capital improvement than hospitals serving principally Latinx or Black serving. So the myth by the Hospital Association is that if you have single payer, hospitals will close. I guess we got to tell that to all the other countries around the world that seem to manage to have comprehensive public coverage and still have more hospitals than we do. But their argument goes as follows. Well, private insurance today pays more than Medicare pays today. Therefore, an all Medicare payment system would mean less revenue to hospitals, and therefore this would exacerbate hospital closures, especially in critical areas. And I would argue each of these concerns, this train of argument, is based on a series of false assumptions. So let's debunk the myth. Private insurance pays more than Medicare pays today. Well, false assumption. Payer mix is not private and Medicare. Current payer mix is Medicare, Medicaid, uninsured, self-pay, charity care, etc. And those that are currently taking their fair share of all payers are those that are financially stressed. Single payer will put everybody on a level playing field. False assumption number 2, well, all Medicare payment model means less hospital revenue. Well, Medicare today has some sort of one set of rates. They would be saying that it would then apply everywhere. Well, that's outright false. Medicare rates today already vary such that hospitals with legitimately higher expenses, interestingly, both the academic medical centers and also rural hospitals, get some additional higher rates. Furthermore, single payer wouldn't be current Medicare rates. It would probably be at about 110% of current fee-for-service Medicare. And by the way, hospitals actually make a profit, a net positive profit on Medicare fee-for-service. So we lose money on Medicare is simply false, according to national reporting, official congressional reporting by MedPAC, which is a combination of CMS and congressional oversight. Hospitals' profit on Medicare fee-for-service was plus 8%. Maryland hospitals thrive under an all-payer model where all payers have to pay the same Medicare rate. And frankly, to the extent that a single payer brings in something called global budgeting instead of fee-for-service, the whole question is moot. And the real point is that transparent, accountable funding results in supporting hospitals based on community need, not on local people's income and wealth. Single payer would reduce the operational overhead. So it ignores the argument that they are making, ignores that single payer is reducing costs. So it's not just what your income is, it's also what your costs are. And since single payer is reducing the hospital's overhead costs for billing and other administration and reducing costs for drugs and supplies and equipment, and is reducing the hospital's cost as an employer, just like it reduces the cost for all other employers that are currently paying in for their employees' health coverage. And these are estimated to be in the range of 10 to 25%. So we have a 10% bump compared to Medicare fee-for-service. We have a reduction of at least 10% in expenses. And in fact, those same 3 groups, Mercatus, Rand, and Urban Institute, all of which are opposed to single payer, in their own analyses, acknowledge that in fact, under Medicare for All, there would be a net increase of funds going overall to hospitals than there is in the current system. Current system shown in red, Medicare for All shown in teal. So again, even the skeptics' own analyses, even the far-right Mercatus agrees single payer would bring more money in to hospitals. Currently, the system is just grossly perverse. We are financing hospitals on the basis of chasing profitable procedures and preferential case mix, and the hospitals game the system for optimizing their billing. You see this in terms of upcoding in various ways, but it's also a matter of, well, let's close the clinic in the South Bronx, but let's open up a clinic on the wealthy west side of Manhattan. So you want to avoid less profitable patients and less profitable types of services. And you want to improve your case mix if you're a hospital administrator, even a so-called not-for-profit hospital, with doing more of the procedures that reimburse better and from patients with better payment systems. And even the hospitals hate the managed care companies. The New York Hospital Association actually ran an ad decrying, which, so on the one hand, they were opposed to the New York Health Act, and on the other hand, they actually ran an ad complaining about the managed care companies denying payments, delaying payments, and then reducing the payments, and then interfering with medical decisions due to prior authorization. And in that ad, they actually touted traditional public fee-for-service Medicare as the better way to go. And yet they still, for some reason, oppose the New York Health Act. Most single-payer systems actually make the whole argument about this reimbursement moot because they talk about global budgeting. So let's have an actual budget ahead of time based on some planning of what the actual community need is. And let's not just open up new facilities willy-nilly wherever we can make a greater capital accumulation investment and return on revenue. These things are predictable, and in fact, they've been done in models in the US. There are models for Massachusetts, Maryland, and Pennsylvania for this kind of thing, and again, all the other wealthy capitalist democracies around the world. Again, there's multiple studies showing that the system can absorb the increased coverage. And again, the whole issue of, oh, somehow this is going to cause rationing is ridiculous. If we have our current system, we have a certain number of healthcare providers, and we have a certain number of patient need today. If tomorrow we immediately go to universal coverage, then we would have exactly the same number of providers and exactly the same amount of medical demand. So if you flip the switch overnight, nothing has changed. The only thing that has changed is that people who didn't have access now have access. So single payer doesn't change the number of doctors, providers, or population or amount of illness. The entire rationing argument makes no sense. This is that great New York hospital ad that I mentioned. So again, single payer, better for hospitals and patients. Critiques. Well, what about the workers displaced from their jobs? Some of those savings are getting rid of jobs in, the billing people at the hospital who are chasing the insurance companies, and the people at the insurance companies that are marketing the plan and then denying care. So basically, all single payer systems pay those people off, essentially. Guarantee that they have money for a certain number of years and either into retirement or real job retraining. The amounts that are calculable and are known. It would also point out that the number of displaced workers is 3% of displaced workers that go on every time. So you would have a 3% bump in the number of displaced workers as a one-time event compared to the amount of churn there is in jobs every year. So that's the amount we're talking about. And unlike that, single payer actually pays those folks. Well, what about my Medicare? I like my Medicare as is. Well, current Medicare recipients would still benefit. Current Medicare is not free for people. They do have to pay premiums for their Part B, for their drugs. If they are in Medicare, get any additional coverage that costs them money under New York Health Act and other single payer, all of that's covered. So it's more comprehensive coverage with less out-of-pocket costs than current Medicare. Well, I don't want a government takeover. I don't trust the government. Well, basically, your choice is the government or Wall Street. One or the other is controlling it. Since then, we've had a takeover of U.S. healthcare by what we might call the commercial determinants of health, starting with the 1973. So this idea that I don't, your choice is government or Wall Street. And I would suggest that government, for all its faults, is inherently more transparent, public, and accountable. So what are the other arguments? Well, the arguments, it'll never happen. So don't bother fighting for it. I choose to fight for the things that are hard, the things that are going to happen anyway. I don't need to fight for. There's an interesting, subtle version of that argument that the system is so corrupt, even if it was passed, regulatory capture would ruin it. I know I'm running out of time. The person who pointed this out was one of the leading health economists who actually helped bring single payer to Taiwan. He was just skeptical about the United States being such a politically corrupt system compared to all those other rich democracies around the world. Republican alternatives basically amount to good for rich people. Health savings account is essentially an insurance pool of one. Go back to how insurance pools work. Low cost premium plans amount to high deductible, high copay out of narrow networks and maybe capped. So they're great until you get sick. And in general, Republican alternatives are less expensive unless you actually get sick and need health care. Conservative Democrats, let's keep chugging on it with quote unquote reform at the margins. And the problem here essentially is that in order to get tiny incremental changes in coverage, you have massive transfer of public money to private insurers. This shows current healthcare system on the left going to an expanded public option in the middle, where you get a little bit closer to universal coverage, but your costs go up because you're not getting any of your good savings. And on the right is single payer with guaranteed 100% coverage, broader comprehensive coverage, and actual savings. This shows what happens between the status quo in green, expanding through a public option system versus single payer in terms of who pays what. And again, this is the progressivity argument that people at a lower income, shown on the left, which should pay, what it means by progressive payment, should pay a lower percentage of their lower income because they have less disposable income, as it were, for health care. And those who have a higher income, as shown on the right, should in fact pay more. And currently, people at lower income are actually paying a higher percentage, as shown with the 9% on the left and the 2% on the right for the orange and green. And under single payer, lower income people would pay less, and higher income people would pay more. So again, let's go back. If you're examining any proposal, I would suggest these are the criteria. Is it universal, simple, and affordable? And I will now stop.